All right, let's talk about cardiomyopathies. All right, the first cardiomyopathy we have is dilated cardiomyopathy. Okay, and in here in the picture, you can see the heart is dilated. That's why we call it dilated cardiomyopathy. Uh, as compared with hypertrophic, which is the muscle mass is a lot, so you have a hypertrophic. Why? Because things have been deposited within the muscle of the cardiac myocytes, and you will see what are those things in that uh, hypertrophic cardiomyopathy. So let's talk first on dilated cardiomyopathy. It's the most common cardiomyopathy, about 90% of the cases, often idiopathic or familial. Familial, why? Because there is a mutation of TTN gene, high yield. There is a mutation of TTN gene. This TTN gene encodes for, what is it encoding for? Sarcomere protein titin. Sarcomere protein titin. So when there is a mutation of this, it leads to dilated cardiomyopathy, high yield. Other etiologies include drugs. What drugs? Alcohol, cocaine, doxorubicin, high yield. Infection, Coxsackie B, Chagas disease, ischemic heart disease, coronary artery disease, systemic conditions, hemochromatosis, sarcoidosis, thyrotoxicosis, vet beriberi. So all of these are other etiologies that can cause dilated cardiomyopathy. But the important thing is, this will be given in history, right? But the thing is, how would you know it's a dilated cardiomyopathy or not? So for that, we really have to look at the findings. This is most high yield. What are the findings? So you will have a heart failure, a patient with a heart failure, with S3 sound, with systolic regurgitant murmur, and dilated heart on echocardiogram. Balloon appearance will be seen on chest x-ray. These are the findings. On top of that, let's just look on the right side first, and then we'll come back to the treatment. On top of that, we also will have, in these patients, we will have systolic dysfunction, and eccentric hypertrophy will be there, which is basically sarcomere added in series. So a lot of things into small thing, but we need a mnemonic for this, because otherwise we would not know. And this is total opposite to whatever is in the hypertrophic. For example, here you have systolic dysfunction. In hypertrophy, you're gonna have diastolic dysfunction. In eccentric, in dilated you have eccentric, where in hypertrophic you will have concentric. Sarcomere added in parallel, sarcomere added in series. So you see the difference. It's just there. S3, S4. So these differences, we need a mnemonic. So the mnemonic is that you can memorize. If you have a better one, that's also good. But one of the easy one that you can go for is called DESLO. DESLO. What is DESLO? D for dilated cardiomyopathy. Dilated cardiomyopathy. E for eccentric hypertrophy. S for systolic dysfunction. Low. What is low? Low is ejection fraction. So with systolic dysfunction, you're going to have a low EF, which is not mentioned here. If you have a low EF here, and what is a normal ejection fraction, by the way? Normal ejection fraction is greater than or equal to 50%. So if you have a lower ejection fraction, that's going to be with dilated cardiomyopathy, because with the hypertrophic cardiomyopathy, the ejection fraction is preserved EF. So let's again look back at the mnemonic. The mnemonic is DESLO. Dilated cardiomyopathy, eccentric hypertrophy, systolic dysfunction, low ejection fraction. And one more, high yield. Whenever you see a systolic dysfunction, it's going to give you a low EF. So, and whenever you have a systolic function, you will have eccentric hypertrophy. So this is not just the mnemonic for dilated cardiomyopathy, which includes systolic dysfunction, but wherever we will see in heart failure, we will have systolic dysfunction. In systolic dysfunction, we will see we will see that low EF is there with eccentric hypertrophy. This is a very high yield point, and a mnemonic, a very high yield mnemonic too, to bear in mind. So now let's look at what else we can see. So it's compare, let's change color here. So compared to the athlete's heart, where the left ventricle and the right ventricle enlarge, that would facilitate the increase in stroke volume and increase in cardiac output. So they're just comparing with the athlete's heart, in which you just have increase in stroke volume and increase in cardiac output. Now stress high yield is stress induced cardiomyopathies. So stress cardiomyopathy is also called Takotsubo cardiomyopathy, which is also known as broken heart syndrome. We have here, all we have is ventricular apical ballooning due to increase in sympathetic stimulation. So what do we mean by ventricular apical ballooning? Simple. So we have aorta and we have ventricle, right? So the apical side is this here. So there's a this is atrium. Let's just do a proper one. So let's just say this is left atrium and this is left ventricle in a proper manner, right? This is aorta. So where would be the apical of the left ventricle if this is aorta? Right here. This is apical. So this apical will balloon out like this, and there will be everything else. There will be contraction of it, but in the apical, it's called hypokinesis. You will see hypokinesis in the apical area. Hypokinesis of this apical area, and that is due to the fact that you have increase in sympathetic stimulation, and an apical will balloon out, and there will be no contraction there, hypokinesis, and that will be seen in stress cardiomyopathy, like a stressful condition. So that is what we have. So as we talked about stress induced, it is the stressful situations like exercise, like post-menopausal women, which will have increase in catecholamines, which it is increase in sympathetic stimulation, which causes hyperkinesis of the left ventricle, except in the apical area it is hypokinetic, meaning there is no contraction over there. And that is all for the stress induced. Now looking at the treatment options, what are the treatment options? So treatment options we have are sodium restriction, because they're going to heart failure, you gotta restrict the sodium. ACE inhibitors, ARBs, beta blockers, sacubitril, diuretic, mineralocorticoids, receptor blocker like spironolactone, ICD, and heart transplant. So these are all the treatment options that you can go for this. Now let's look at the second one, which is hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, it's 60 to 70% of the cases are familial. Top one, what was that? About most cases, 90% are idiopathic or familial. Here is 60-70%. Autosomal dominant, most commonly due to mutation. High yield again. Mutation is in the gene encoding for sarcomere proteins such as myosin binding protein C and beta myosin heavy chain. So what was the mutation in the top one? We had a mutation in TTN gene, which was encoding for sarcomere protein titin here, right? And here is again the sarcomere protein, but not the titin. Again, both are sarcomere protein. Problem is in sarcomere protein. But over there, that's the problem in the TTN gene causing problem in titin here. Here, the problem is in the myosin binding protein C. So let's just write that. Myosin binding protein C. And beta myosin heavy chain. Both of these could be problematic in hypertrophic cardiomyopathy as a familial cause. Other than that, you also can cause syncope during exercise, and may lead to sudden death in young athletes due to ventricular arrhythmia at high yield. Young athletes, they go in death, sudden death, due to hypertrophic cardiomyopathy. So syncope during exercise and sudden death due to ventricular arrhythmias. Findings are also high yield. Again, you have S4. The easy way to remember this S4 is, so in this book, in all the first aid books, you have dilated first, and then you have this hypertrophic second, right? So whatever is top is S3, then the S4 comes. That's one way to, if you're not getting the point, then you can just say, okay, S3, which one was up top? Okay, dilated was up top, so S3. Hypertrophic is at the bottom, so S4. Okay, systolic murmur, again, may see mitral regurg due to impaired mitral valve closure. Treatment is cessation of high intensity athletics. Cessation of high intensity athletics. Use a beta blocker or non-dihydropyridine calcium channel blockers like verapamil. ICD if a high risk. Avoid drugs that decrease the preload, diuretic and vasodilators. Now, important thing again, going back to the basics here, and that is, these things are important, that you will be given someone with an hypertrophic cardiomyopathy. They will have a dystolic dysfunction with a preserved ejection fraction, with concentric hypertrophy, and sarcomeres added in parallel. So how can we? There are two ways, right? We could use the top mnemonic that we have, DESLO, and we say opposite to that is going to be the hypertrophic cardiomyopathy, or you can just make a new one and say whatever the new that we are making is going to be the mnemonic for hypertrophic cardiomyopathy. One thing that I can help you with is, I don't know if it's a good mnemonic or not, but you can say hypertrophic. Hyper instead of hypertrophic. Hypertrophic. So what are we talking about in hypertrophic? So for P, we are saying parallel. So they are added in parallel. So sarcomeres are added in parallel. For D, we are looking at diastolic dysfunction, right? And for again, P is for your preserved EF, ejection fraction, and for C is the concentric hypertrophy. So this could be one way that you could memorize, or DESLO, and just know that the opposite of DESLO is going to be hypertrophic cardiomyopathy. But important thing, again, going back to the normal things here, important thing being highlighting this thing: diastolic dysfunction, concentric hypertrophy, preserved ejection fraction, added in parallel with S4, systolic murmur, MR could be seen, and sarcomere proteins are defective, and causes could be, it can cause syncope and sudden death. Okay, now looking at the next point here, what do we have? It is classified as hypertrophic obstructive. So HOCM, hypertrophic obstructive cardiomyopathy, when left ventricular outflow tract is obstructed, right? Asymmetrical, high yield asymmetrical septal hypertrophy and systemic anterior motion of the mitral valve, which will cause outflow obstruction, which leads to dyspnea and possible syncope. Okay. So here all you have is when you obstruct. So when you have the hypertrophic obstruction of the left ventricular outflow, this creates a systolic murmur, right? It will, when you can't, let's say that this is left ventricle, when in systole you're trying to push the blood into aorta, and that blood, because of an obstruction here, it's gonna make a sound, right? So that will give you systolic murmur. So that is exactly what they said here. It's a systolic murmur will be seen. Okay, that is one thing. The other thing is you will have asymmetrical septal hypertrophy. So septum is right here. This is septum, right? So it is asymmetrical septal hypertrophy. High yield point. That it is not going to be symmetrical. It is asymmetrical septal hypertrophy. and systolic anterior motion of the mitral valve. So there's anterior motion of the mitral valve, which causes the outflow obstruction. And when you have the outflow obstruction, then that's going to cause dyspnea and syncope. So over here, what did we look at? We said this is going to cause dyspnea and syncope here, and later on can lead to death even in young athletes. Okay, other causes of concentric left ventricular hypertrophy are chronic hypertension and Friedreich ataxia. So chronic hypertension and Friedreich ataxia. And that is all we have for hypertrophic cardiomyopathy. So looking at the last one here, we have restrictive infiltrative cardiomyopathy. In restrictive infiltrative, as the name suggests, either you're infiltrating, causing restriction in the cardiomyocyte. So these are post radiation fibrosis, Lafler's endocarditis, endocardial fibroelastosis, which is thick fibroelastic tissue in endocardium of young children. So if some young children comes up with this, then you're going to think about endocardial fibroelastosis, amyloidosis, sarcoidosis, and hemochromatosis. The mnemonic here is also pretty good. Please help. Again, you want to think about radiation, anything that would cause cardiomyopathy, irradiation, Lafler's, or you can think about specifically in child, if there's a child wouldn't go into post radiation. So with the child specific, you're looking at fibroelastosis, which is just thick fibroelastic tissue within the endocardium of a child, young children. Amyloid can deposit, sarcoidosis and hemochromatosis can also deposit here, as in causing infiltrative cardiomyopathy. And all of this is basically, this is your endocardium, myocardium, epicardium, right? So when you are obstructing your endocardium, infiltrating the endocardium, what's going to happen is when you infiltrate the endocardium, you restrict the filling, right? There's going to be restriction of filling. When you restrict the filling in diastole, right? So what's going to happen is diastolic dysfunction, because the filling is restricted. So let me actually draw one more time. Here is your normal heart. But now when you deposit all of that in this endocardium, what's going to happen is you have restricted the filling, called diastolic dysfunction, which is same thing what we seen where in a hypertrophic cardiomyopathy, diastolic dysfunction, because there is no filling. You can't fill it because the muscle here was enlarged. But over here is the infiltration of whatever that infiltration is, or either the radiation that caused fibrosis, or fibroelastic replacement, or hemochromatosis, iron deposition, anything deposition has been occurred that cause decrease in filling. When you decrease the filling, you're going into diastolic dysfunction, and diastolic dysfunction issues, right, can have low voltage ECG despite thick myocardium, especially in amyloidosis. Lafler endocarditis is associated with hypereosinophilic syndrome. Histology would show eosinophilic infiltrates within the myocardium. So with the mnemonic for this Lafler one is going to be your E's. So Lafler, eosinophil, right? E for Lafler, eosinophil, so eosinophils. So you will see the Lafler is associated with eosinophilic syndromes, hypereosinophilic syndromes, and you will see eosinophilic infiltrates. So E's, all the E's with the Lafler. What else we might have here? Other than this voltage, so we said we have a low voltage One thing is low voltage ECG. Okay. Other than that is diminished QRS amplitude. The other point you will see is they will have diminished or low QRS amplitude. Okay. And that is going to be all for restrictive. Now looking at let's just review this together and then moving on with the next one. So cardiomyopathies. Cardiomyopathy, simple thing. For dilated cardiomyopathy, we can see here it is dilated. Why is it dilated? Because there is an eccentric hypertrophy when we add the sarcomeres in series. So let's look at the mnemonic. The mnemonic is DES low. DES low, D for dilated cardiomyopathy, E for eccentric hypertrophy, S for systolic dysfunction, low for ejection fraction being low. It is most commonly idiopathic or familial. In familial, you have TTN gene mutation, which encodes for the sarcomere protein titin. Other things are here. Etiologies, drug, ischemia, anything you name it is here. Other than that, S3 heart failure could also be seen here, and ballooning appears on the of the heart on the chest X-ray. Important thing is a stress cardiomyopathy, which is stress induced, in which you increase the catecholamine. In which any stress, exercise is also a stress. Postmenopausal woman is also a stress. Any stressful condition, you increase catecholamine, that causes increase in sympathetic stimulation, that causes hyperkinesis of the left ventricle, but hypokinesis of the apex of the heart of the left ventricle. Okay, and for hypertrophic cardiomyopathy, we can't even fill the heart, so it's a diastolic dysfunction due to the fact that there is a concentric hypertrophy in which we have the sarcomeres, they're added in parallel. Okay. Familial cases when there is a mutation in the sarcomere protein, such as myosin binding protein C and beta myosin heavy chain, causes syncope, sudden death, or dyspnea. S4 will be seen here. Systolic murmur and MR could also be seen. Classified as HOCM when there is a proper left ventricular outflow obstruction and asymmetrical septal hypertrophy will be seen. Other than that, you will also see other causes of concentric left ventricular hypertrophy are going to be your chronic hypertension and Friedreich ataxia. For restrictive, infiltrative, please help is the mnemonic, in which you have the post-radiation, Lafleur's, endocardial fibroelastosis seen in children, hemochromatosis, sarcoidosis, amyloidosis. Again, all of that you can't fill the heart, diastolic dysfunction. But here instead you will have some ECG problems like low voltage ECG, low voltage meaning low QRS amplitude, and Lafleur is E for eosinophils, eosinophilic infiltrates. And that is all for this one. I just want to add one more point, and that point is going to be athletes' heart adaptation. With the athlete's heart, there are a couple of adaptation which responds to high endurance training. High endurance training leads to increase in volume load on the heart, right? When you increase the volume load on the heart, which essentially means increase in cardiac output with small increase in afterload. So as a result, predominantly with the athlete's heart, what's going to happen is predominantly your eccentric hypertrophy is going to, you will see eccentric hypertrophy. And that is basically enlarged left ventricular cavity, right? Cavity size, enlarged left ventricular cavity size will be seen. But also on top of that, with athlete's heart, you will also see some degree of concentric hypertrophy with uniform increase in left ventricular wall thickness. Okay, and why is that all important? Because in athlete's heart, what you will see is so let's just do this here. You will see is there will be increase in left ventricular mass. There will be increase in the cavity size. Left ventricular cavity size will be increased. Cavity size. And there will be increase in wall thickness. wall thickness. So here, if you look at these two pictures, you see the cavity size increased in dilated. In hypertrophic, what do you see? You see muscle size is increased, which is your increase in left ventricular mass, or in an increase in wall thickness. So in the athlete's heart, you see sort of both eccentric hypertrophy and concentric hypertrophy. And that is the fact that with the athlete's heart, you have, as a result of this, they are at a low, their normal resting heart rate is a pretty lower than the average adult. So they have a lower resting heart rate. And that is all for the athlete's heart adaptations.